Thank you very much for inviting me to talk about post-cure care. So I would like to start with the acknowledgement that we do in Canada that is related to the lands that we usually are either based or are gathered or we do our work, and give our gratitude to the indigenous peoples on whose land we usually are based. So this is like the place where I'm based. It's called British Columbia Center for Disease Control, and it's based on the lands of Coast Salish people in that area. And we're really privileged to be living and working in these lands. So what I will do is I will set the stage with respect to differing profiles of people who are living with hepatitis C. And most of that is based on data from North America, mainly from Canada, but I will try to generalize it to other settings as well. And then we'll talk about effect of DAs on outcomes, and then post-cure HCV surveillance and some work related to reinfection, and then we'll summarize some of the discussion. So this is some of the data that came from our earlier work, where we were trying to understand the profiles of people living with hepatitis C. And when we look at North America and Canada, so there are people who were born before 1965, and these are people who acquired infection for some time ago, and now they are presenting with end-stage liver disease. They have low risk of transmission. You see like very low injection drug use, mental illness, HIV co-infection, and alcohol use. But then in contrast to that, in the younger population, you have very high injection drug use, mental illness, HIV co-infection, and alcohol use. So that kind of like create a contrasting group of people. For older cohort who are presenting with end-stage liver disease, you need treatment and then post-cure HCC surveillance and management of complications, while in the younger population, you need, along with Hep C treatment, management of co-occurring conditions. We did some further analysis to further granularly look at, can we further classify these two groups into multiple groups, and we were able to see some distinct characteristics across various classes that has helped us to understand and think about like how service delivery or care could be organized across these groups. For example, people who inject drugs could be divided into those who are younger versus older. Similarly, baby boomers could be divided into those who are living in urban environment versus rural environment. And then one distinct group that comes out from this overall is people who are from Asian background. So these are mainly from East Asia and South Asia, and they don't have like the traditional risk factors that we see in developed countries related to injection drug use. Mainly infections were acquired through unsafe medical practices among these populations. As you know, that in most places, therapy was based on fibrosis restrictions, which were, at least in Canada, were lifted in 2018, but that created an artificial distribution or profile of people who were treated early on after availability of DAAs, and then how things moved on. So when we look at these profiles, so you see that early on we treated people who had advanced fibrosis and cirrhosis, and very few people who were living with substance use disorders and so on. And as we lifted these restrictions, and now we are treating more and more people with substance use disorder, and that has implications with respect to what kind of care we need to provide these two groups of people. So that brings me to the post-cure care then could be tailored based on the type of profile that people have. For example, people with advanced stage liver disease need care for liver failure, hepatocellular carcinoma, and extrahepatic complications, while people who inject drugs, a lot of that is related to high drug-related mortality and high risk of reinfection following cure. So we'll dwell a little bit more around both of these areas. So this is some of the data from our group, but a lot of data has accumulated related to impact of DAs on outcomes, and this is specifically related to mortality, all-cause mortality, and liver-related mortality, and drug-related mortality, and we see a significant decline in all of these outcomes following a DA treatment. But when we, and that data was in comparison of people who achieved SVR compared to those who were not treated. But when we compare people who achieved SVR to those to general population, the mortality rate is still quite high. So it's about 3 to 14 times higher in those who are treated compared to general population, depending on the group. So in this study, we looked at data from British Columbia, Scotland, and England, and we see that among people who were pre-cirrhosis, so their mortality was high, but the mortality among those with cirrhosis and end-stage liver disease was much higher. So what were the causes of these mortality? And that could be divided into two areas. Among people with pre-cirrhosis, and data was only available from British Columbia and Scotland, so most of mortality was related to opioid overdose or drug-related mortality. But when we look at the people with cirrhosis and end-stage liver disease, most of mortality was related to liver failure and hepatocellular carcinoma, and some related to other cancers. But these data are, especially among those with pre-cirrhosis, cannot be generalized to situation in low middle income countries, especially when I look at the data from Pakistan or some other countries. So most infections are not related to injection drug use, but they are related to unsafe medical practices. And that is where we need to look at what kind of profile these people have and what kind of care is needed for these populations. So when we look at, we talked about impact on mortality, but then we see similar impact on hepatocellular carcinoma as well as on hepatic decompensation. Same from our group as well as from large number of other studies where we have seen that. And I was trying to think, do we have any data from low middle income countries where we could contextualize some of the post-cure care? And I took some of this data from Pakistan. This is not related to a treatment, but this provides a distribution of age and sex distribution of people who tested positive for antibodies in the provincial survey in Punjab province. And you could see that there are a very large number of people in older age groups above 40 years of age. And these people may have had infections for quite some time, and given treatment was very low, and even when we will treat these people, they will be at the risk of developing complications, and they will be in need of ongoing surveillance and monitoring related to liver and non-liver related complications. So what are some of the implications within these settings? So definitely we will need to scale up screening, as we know that large number of people are still undiagnosed, and then also treat them. But then from the post-cure point of view, we will need to set up HCC screening and surveillance, and then the HCC surveillance data are not available from a lot of countries. This is a meta-analysis that was published a few years ago, and it presents that mix of data from a lot of different settings, but the overall, when we look at the average uptake of the surveillance, it was about 24%. And there is a huge variation by specialty, much higher rate among subspecialty clinics compared to the broader primary care or internal medicine or other places. And this is a more recent data from UK, where they saw that only 9% of people had biannual HCC surveillance. And then one key point that came out from this study was there was decline in proportion of those who were who had surveillance over a period of time, and that reached about 19% by year 3, and overall it was 9%. And that is a very important point. Like early on, we see increased uptake following treatment, but then as time passes by, that declines, and that may be okay as we go along. But this is where we have some data gap related to what is the risk over a period of time. And there are some data that suggest that risk over time declines, but it's not very strong, and we need to generate more data related to that. So within the same study, we see that with every increase in episode for screening, there was increased uptake of curative intent treatment for HCC. So there is a direct link related to as uptake of surveillance and the curative HCC treatment. And then we know from a lot of different studies, here I'm showing one study related to the cost effectiveness of HCC screening, but we know from data from large number of studies, HCC screening is cost effective. And in this one, within people who had cirrhosis, surveillance was cost effective to age 70. And then among those with advanced fibrosis, it was cost effective to age 60. And there are like a lot of, so we talk about surveillance mainly among people with cirrhosis and then those with advanced fibrosis, but there are a lot of other factors which are important from the post-cure point of view, and alcohol is one of the most important factors which are associated with increase in fibrosis progression and HCC risk, and there are data that shows that the continued use of alcohol following cure, as well as increase in use of alcohol following cure, and that is an area where we will need to pay more attention to in terms of generating more data, but then also intervention to reduce the risk. Similarly, diabetes at the baseline, even after cure, could increase the risk of HCC. A lot of emerging data suggests that following SVR, there is increase in weight gain and BMI, and that could then, along with diabetes, and then some of the steatosis and MAFL could also lead to increase in risk of HCC and advanced stage liver disease. So we need to look at some of these aspects. So in this review by Professor Nagro, like they were trying to look at how we identify people for optimal surveillance. And so there are some baseline characteristics, and then there are characteristics that are important during the post-cure time frame that could be used to create some algorithm for identification of people who could benefit from surveillance. And some of the data suggests that risk prediction, even based on the non-invasive markers FIF4, could help in risk stratification, especially in absence of cirrhosis. And that has important implications for resource-limited setting where we may not have ability to do ultrasound every 6 months. So just to summarize this, overall rate of HCC surveillance is very low and higher uptake in subspecialty clinics. So we will need to look into promoting HCC surveillance in primary care. Patient-provider education, in-reach, and other interventions have been effective in increasing uptake. So now shifting to Hep C reinfection. So this is data from our group where we looked at people who had recent history of injection drug use, those with the past and none, and we see that those with the recent history of injection drug use, reinfection rate was higher, and it was, if you look at the overall rate, it was 4.39 per 100 person years, and about 30% of people had reinfection by year 5. This rate is lower than some of the other studies, but that may be related to the overall population-based data compared to some of the cohorts where people are more closely followed. But this, in essence, highlights the risk of reinfection following cure. So who are people who are at the risk? It's younger PWID males and those with the opioid use history and HIV co-infection. When we look at the protective factor, just similar to some of our previous work and other work. Antipsychotic treatment, OAT, especially longer duration of OAT, is associated with significant lower risk. Just to summarize, prevention of reinfection, access to sterile injection equipment, opioid agonist therapy, and other treatments for drug dependence, especially for stimulants, management of mental health disorder, psychosocial support, especially community and peer-based models for prevention and care education will be important. Management of other co-occurring conditions in this population, and the management of the overall broader health and well-being of the population. So one important gap that I see, lack of data on reinfection risk from low middle income countries related to unsafe medical practices. That is an important gap that we need to bridge data, because most of infections are in developing countries like Pakistan. So where post-cure care should happen? So this depends. But as we are moving to the broader elimination and thinking about how we set up and integrate with the broader care, it may vary from primary care to specialists, but we will need to move this to primary care. So I will end with this summary. So if you look at all people who achieved SVR, so we need to optimize their metabolic profile, alcohol abstinence or lower level of alcohol, control diabetes, and strive for ideal body weight, treat hyperlipidemia, and so on. And then with people with risk of reinfection, perform at least annual HCV testing, management of co-occurring conditions, and psychosocial support and support for overall health and well-being. And among those with advanced fibrosis, imaging, liver function tests, and upper endoscopy if cirrhosis is present, and clinical evaluation for progression to cirrhosis and hepatic decompensation. Thank you very much for your attention. Thank you.